Also an associate professor in NYU Langone's Department of Population Health, director of the Health Evaluation and Analytics Lab, a joint initiative of NYU Langone's Department of Pop Health and Wagner School of Public Service, focusing on research and evaluation that improve administration of New York Medicaid program, while at the same time having an eye on national policy and contributing to that. So, okay, without further ado.
Thank you. Thank you for the nice introduction. In fact, I'm a little bit worried. Steve gave most of my talk already, so I don't know what I'm going to talk about. So, you know, it's a real delight for me to be able to be invited to have a conversation, you know, here at Rutgers. And in a moment, you'll understand why. So just to talk a little bit about my professional journey, I initially got an MBA from Indiana University and went into the corporate world for a while and decided sort of like I wanted sort of a different professional direction. So at that point, with the help of some friends, decided on getting a degree in clinical psychology and started at Rutgers University in 1993. And so, you know, and there sort of met a lot of people who have been very influential in my journey, including Anna Leary, Brenna Bree, Barbara McCready, John Morgenstern. And, you know, one of my first conversations when I got there was, you know, I was about to embark on being a clinical psychologist. I thought I was going to be in the academy wearing a tweed jacket with, you know, with the leather patches on the elbow. I thought that was going to be my life. But Terry was encouraging. Yes.
Fantastic person, Terry Wilson.
Yes.
Wonderful. Just a guy. I never got to know him very well, but one of these scholars who you meet and instinctively you know that this is somebody who knows a shit ton about what he's talking about. So that was really nice that you got to work with him.
Yeah, as a young person would say today, he was wicked smart. And he was encouraging me to sort of like, you know, take that in business background and incorporate it into what I was learning and sort of, you know, as I'm progressing to my future, sort of like integrate those and sort of like, you know, and you know, from his perspective, sort of make the business case for clinical psychologist. As you'll see, my career has led me into a direction where you wouldn't know that I'm a clinical psychologist based on what I do, but sort of like it is about sort of integrating sort of different perspectives and sort of in the work itself. So thank you. I'm glad to be back. And even though everything's so different than it used to be. Did that work? Okay. So just very quickly, I'm going to give an introduction to the New York University NYU Health Evaluation and Analytics Lab. And in a moment, you'll see sort of we work closely with the state government and across a number of different administrative databases. We also work with other research collaborators, and Steve is one that we've done some work with in addressing many different kinds of questions related to sort of the well-being of New Yorkers covered by Medicaid. You know, I'll give a quick overview of the Medicaid side of the lab, but then sort of I'll direct the majority of my comments to what we are doing in the addiction space. So the overall mission of the lab is really to sort of like, you know, do scientific studies that support, you know, sort of the work that the state is doing. You know, we get access to the Medicaid data because, you know, we pass that litmus test that sort of like says that we're helping with the administration of the Medicaid program. Similarly, and I'll speak at length to this, sort of we have a tight relationship with the Office of Addiction Services and Supports in New York. And a lot of our work is in alignment with what they think is important. And, you know, and you'll see examples of that. But what we think of is, you know, and a lot of this is similar to work that y'all are doing. So I'm sort of excited about this kind of dialogue where we're doing similar things, but then sort of like, you know, maybe there's opportunities for having continued conversations. Because the thing is that the states are working laboratories, but there are lessons one presumes that there are lessons to be learned here that are relevant to the whole country. just to, sort of repeat what Steve already highlighted, the HEAL Lab is a joint venture between the New York University Wagner School of Public Service. So there's a big focus on public administration, developing the workforce for public administration there. And the school of, the Grossman School of Medicine, and specifically the Department of Population Health. So there's a population health lens across many of the studies that we get to participate in. Access to large administrative data is a big focus of ours, but and there's a number of different kinds of studies that we can do with that. I do want to highlight that, over time we've, seen the value of blending in qualitative work to get at the story that's happening behind the data. So we think it's sort of like one needs to go with the other to sort of really get a full picture of what's happening. What is important part of our ethos is the sense of partnership that we're working closely with the policymakers, and we sort of like are the brokers for the data for many other partners that want to sort of like work with the data to sort of like explore sort of how they're providing value to the state. So we do work with community-based organizations or health systems in using these data to sort of look at the value added of what they do. But all along, sort of like it's this partnership with the state, in large part with the Department of Health, which in New York has the Medicaid has the purview over the Medicaid program, and then the single state agency that regulates addictions treatment, which is OASIS. And there, like, the building trust and sort of like a sense of sort of like, we understand sort of their charge, the level of responsibility that they hold, and we care about the questions that drive what they do. That sort of like, bond that we have established really helps us to sort of continue with the work. And I just want to say the obvious, which is sort of like it's built, those kinds of relationships are important to be able to do this kind of work. Just to highlight that the lab itself has essentially two cores to it. There's one core that has been in existence in the time before I arrived at NYU. I joined NYU in March of 2020, and I'm now sitting in the seat of Jim Nickman, who was one of the people that helped establish sort of the HEAL Lab. And he, together with John Billings, and John Billings is the one who had, with a former commissioner at the Department of Health, established this sort of like unique relationship where NYU has full access to the Medicaid data warehouse in New York, and are able to sort of like, we are sort of data stewards. We are able to sort of like, work with the data, but also sort of like help the state in sort of like, working with other investigators and ensuring that they're using the data in a way that's sort of consistent with the laws and sort of the interests of the state. So most of my talk is not going to focus on that. The other side of the house that's sort of been really growing rapidly recently is a focus on the addictions treatment system. So we call that the Addictions Health Services Research Group. And most of my talk is going to really focus on the work that comes from that. And it's the team that's growing. So, at the beginning, at the end, I want to give kudos to sort of the people who helped me be here today. Just a little bit on the Medicaid side. New York State has a very large Medicaid program. Currently, these numbers are a little bit old. Currently, it's a little bit more than $90 billion in full sort of funding for the program. New York, sort of, supports part of it. The federal government supports part of it. The program has a generally comparatively rich set of benefits. So there's a lot of opportunity here to research different aspects of healthcare delivery that are supported by the Medicaid program. And, importantly, addictions is sort of, very highly supported under the Medicaid program. And I'll speak to that in a little bit. It also covers a large proportion of the New York State population. This is the more vulnerable part of the population. So the questions that we ask are really focused on sort of like, some of the most vulnerable members of society. And sort of like, and there's a lot of other factors that are that we must take into account in the research. Did you have a question?
Just very quickly, the color coding
Um,
on the map, I'm just wondering if it signifies.
those are different sort of, you know, and there's many different ways to divide into New York into regions. So this is one of them. You know, Medicaid. Yes, yeah. Well, these, you know, these are different sort of like, you know, economic zones for New York. Yeah. I had to think a bit. So this slide, that part is old, so I had to remember. Because of the richness of the data, we've been able to explore many different kinds of questions, and we do this in partnership with other investigators. Again, everything passes the litmus test and you know, and the state has to approve every project. But a large focus on behavioral health in our shop. But also sort of, you know, we have, you know, and this is per chance, sort of like a group of investigators very interested in maternal health. You know, sort of like, and a lot of studies on focus on health systems, different kinds of health services research. And a lot of people are really interested in health-related social needs, social determinants of health. This is sort of the new CMS code word for that. In fact, New York just got approved an 1115 waiver that provides, you know, more than $3 billion to support through Medicaid dollars, services that are, you know, they categorize as health-related social needs. And so some of that money is to pay, and they have to build the infrastructure for this. So this is all emerging. You know, community-based organizations to provide housing supports, nutrition, and transportation. But broadly, it's about funneling Medicaid dollars to community-based organizations. So that's on the horizon for us, and there's going to be a lot of interesting stuff to explore there. I'm going to pivot to the addiction side of things now. And Kylie, can you just give me a sense of, like, I want to stop at 15 minutes before, just because I want to allow time for, so give me, you know, before that, like some signs I get to speed it up if I need to. Okay. I'm not going to belabor the point that sort of addictions has a broad penetration within sort of like, you know, all communities, including the United States. Very large, substantial number of people are affected by substance use disorders. Relatively few of those individuals actually go into formalized specialty care treatment for substance use disorders. And among those who do, it's a longstanding sort of like challenge, and it's been well recognized that the available treatment that's out there is subpar. It's dated in old models, doesn't necessarily incorporate some of the current thinking that's driven by recent scientific discoveries, as well as sort of findings on what is evidence-based practice. And it's been, for as long as I've been sort of in the field, sort of like a real challenge to sort of really get, you know, the new practice adoption. And that's a big part of like what we're interested in. And you'll see in a minute, we have a very systems perspective on it. Part of the problem with this current system is sort of it's marginalized. There's a lot of stigma associated with substance use disorders. So the system itself is, you know, it's, you know, kind of nominally known as sort of part of healthcare, but it's really marginalized within healthcare. So it's not very, very well integrated, even though it draws from some of the same funding sources. And there's not a lot of good connectivity between substance use disorder treatment providers and the rest of healthcare. So there's a longstanding sort of a call for sort of better integration, and it's been hard to sort of make that happen. It's, you know, it's underfunded, so very few resources in these programs, and the workforce that you know, staffs most of these programs don't have, you know, like by and large, like very high levels of education, and often are trained in older models of treatment that sort of are not aligned with new current thinking. And so there's a lot of questions about workforce change within the system that sort of we're all battling with. I do want to highlight that a disproportionate share of treatment for substance use disorders is paid for by government. So government, you know, whether it's at the federal level or the state or local community level, has a large stake in sort of like improving quality of care for individuals affected by substance use disorders. So bringing the lens on specifically onto New York State, the specialty care system in New York is quite large. There's almost 1,000 providers. The bulk of it is an outpatient system, a very large residential care system that Jennifer and I are going to talk about at some point. There's, you know, roughly a couple of 100,000 individuals who are served in the system each year. And a lot of funding that comes from the state aid that's funneled through OASIS, the state agency that oversees addictions treatment. It's also New York is, as a regulatory environment for addictions treatment, there's a larger sort of involvement of the state agency in sort of trying to drive system quality than you would see in many other states. So there's a lot of, there's a lot of funding that comes to these providers through the state agency, but there's also like the state agency has a lot of influence. What's been interesting to see over my 16, 17 years plus of being engaged with the system is sort of like the system also has a way of pushing back. And so, that interplay is always very interesting to observe, but also quite a challenge. So like, and seeing new commissioners come on and getting, as they kind of like ramp up on understanding the politics behind the whole system is part of the story. Did you want to say something, Steve? Okay, good.
I just agree.
Yeah, got it. So just to underscore the point, we work very closely with the leadership at the Office of Addiction Services and Supports. I'll just call them OASIS from here forward. And, we're looking at the whole system of care to sort of see what we can do about sort of quality improvement for the whole system. And as you'll see, sort of like, exploring data to do that, but also sort of a quality measurement and management is a big part of the picture. And it's even more so under the current commissioner. Steve alluded to this, but Shanazo Cunningham has been commissioner for a little bit more than 2 years now. She was a well-established NIDA-funded researcher before. She's a physician by training, general practitioner, who had practiced for many years in South Bronx, so a very sort of like socially challenged area. So, a real sense of commitment. And somebody who has like three important priorities. So one of them is health equity, and sort of like, that's important, all the initiatives that OASIS does. The second is that she wants to sort of imbue the whole system with harm reduction principles, something that is it's remarkable. She's come on board, and a year later, everybody says they're doing harm reduction. So that's the story for another, like in the Q&A, maybe, if you want. And then the third is she wants a data-driven system. And, and that the importance of that will come out in a little bit later on in the talk.
Just to throw in something that Charlie and Chinazo shared with audiences at I guess was it the 4 meeting, that may be of particular interest to us is that you have and it's really structurally rather similar to the distinction between what we have in New Jersey with DMOS versus Medicaid, that OASIS is trying to manage a system that where Medicaid is one of the big payers. They don't run Medicaid, and they don't run, as the health department does, what happens in the hospitals and the EDs. So that, creating that link and working with the state agencies that themselves don't necessarily have access to each other's data very, very easily. This is something that comes up a lot, and it's a familiar story in New Jersey, where also, even though they're within the same cabinet level agency, Medicaid and mental health and addiction services are quite distinct enterprises.
Yeah. And broadly speaking, sort of the story about sort of like, the difficulty it is to share data across agencies is sort of like, sort of like an important parallel here to sort of understand. And a frustration if you're a commissioner who's data driven, who wants to sort of, like get vital statistics data to understand where overdoses are happening and how to link that to programs. That's near impossible. Like, they're still working on it. And at the commissioner level, there's a commitment to be sharing data. It's like when it goes down into the bureaucracy where it becomes challenging. We've been sort of like, my work with OASIS has gone on for 17 years or so. And so we've been part of many conversations, some of them when, for example, when New York decided to sort of carve in to managed care, the outpatient behavioral health, system. So let managed care take care of it, but they wanted safeguards. So they wanted a tool for determining who got into what level of treatment. So we helped the state develop that tool, and it's been used more than 2 million times now for level of care decisions. We've also, when there was a real push in Medicaid to sort of, move the system towards value-based purchasing. And, but, as you all know, sort of there's a real dearth of good quality measures for substance use disorder treatment and sort of like, and how, and which is a rate limiter for how many, value-based purchasing contracts you can sort of like, create in this space. So we were there in the room with them. So as they worked with the Department of Health to sort of really kind of identify what are viable measures there. So we try to be supportive of their mission, and then that also leads to sort of like work that we do together where we get funding from other parties. I do want to underscore the administrative data component that Steve, you were just alluding to. OASIS does have access to Medicaid data. We separately have access to Medicaid data. OASIS has data that they collect from the system, and there's something called the client data system, which is the data, was the foundation of that is the data that's required to report up to TEDS, which is to SAMHSA. And it has a lot of information at admission and discharge for everybody going into addictions treatment. So you have a full registry of addictions treatment that has a lot of information, and New York has embellished it. So like it's richer than what you see in TEDS. Data set that includes information about the characteristics and the clinical profile of individuals that are in treatment.
So the $64 question, you have those data integrated yet?
That's what I was going to brag about just now. So we've merged them. So New Jersey has NJ SAMS, which is the same thing.
Right.
And so, fortunately for us, we're being, OASIS already has access to the Medicaid data, so we've worked with them to how to, to merge them, and it ain't easy. Yeah.
Right.
And then, I want to highlight that we do qualitative studies, behind everything that we do. So, I just want to underscore this idea of like having a systems perspective and looking at things like an onion, like there's multiple layers of, how you kind of think about quality improvement. I mean, ultimately what we want to do is affect what's happening at the clinical encounter between provider and patient. And each one of those parties is coming to that conversation with different characteristics. And there are generally nested within organizations, and with the help of Tom Diano, who's like one of my mentors and somebody that sort of like I really lean into. He's somebody with sort of like a rich history of organizational management and specifically organizational theory, sort of like how to frame the kinds of questions that we do that have to do with sort of organizational level factors that affect quality of care in the room. But then taking into account that all of this is nested within healthcare systems that are funded by Medicaid, and each one of these patients has an interaction with other healthcare providers that we have to take into account in thinking about sort of the whole health benefits to the person. But there are other sort of institutional players that are within the healthcare within the addictions treatment system that these patients are interacting. Very importantly for addictions treatment is the criminal justice system, and and just to sort of kind of like play out the story a little bit, the addictions treatment system has really relied on the criminal justice system for a lot of its referrals, but also sort of like it was the leverage point for keeping people in treatment, because there were sort of many of these people were in probation and parole with mandates. There's been criminal justice reform in New York, which has started in 2020, most recently, which has sort of really kind of driven down the level of referrals and also the ability to use these mandates as leverage over the patients, which is affecting the system. So that's something that's very interesting to sort of like observe. And then at the local community level, the social determinants of health are something that we really need to understand, sort of the level of resources within each community. And all this sort of like just to say, we're working with the policymakers and to sort of help them. Until when do I have? Okay, so I want to. Okay, I'll speed it up a bit then.
10 minutes.
Okay. So, this kind of collaboration partnership between us and sort of the government partners has gotten us really like strong receptivity at the federal level for funding, both in review and as well as sort of, support from NIDA, the National Institute on Drug Abuse. So just to quickly go, we have currently five projects that five grants that are sort of, from NIDA. the one, I'll speak a little bit about the first one, which is our oldest one. That's going to wrap up in the near future. But that's, and I'll explain a little bit more about that soon. We have a study where we're exploring sort of the fallout from COVID-19, the public health emergency, and all the measures that came with that. I'll speak a little bit more about that. We have a specific lens on transition-aged adults, these young adults who are sort of where there's a high need, but they're not really engaging with the system, and when they do, they're not faring well. So we're very, a very targeted study on them. And then I'm just going to keep speeding along here for a second. And then we have a project, and this is another one of the COVID knock-on, as Steve, was the term that Steve used earlier today, which is sort of like, changes in SAMHSA guidelines for methadone take-home medication that we have in the field. I can come back to that later on if there's interest. And then finally, we have a recently awarded research center focused on quality measurement and management, and I'll talk a little bit more about that in a second. Just to speak a little bit about COVID, there's a few projects where I've had overlap with Steve. One of them was a grant from the FOR Foundation, which is a foundation for opioid response efforts, where we were looking at using this methods to sort of really explore what was happening, just in those the year or two after COVID. And that led on to like an R01 grant from NIDA to sort of really look at the knock-on effects. And as you all are well aware, so with the public health emergency came a lot of dramatic, it was an exogenous shock to the whole system. There was a lot of forced changes to providers to adopt things like telehealth, reduce reliance on toxicology to sort of monitor substance use, which was the old model. Kind of like the business model from before really relied heavily on group participation, but that was less tenable with with a telehealth model. And with methadone, there was a real push from both the federal government and the state government to say, stop requiring individuals to show up at your clinic and stand in big lines to get their daily medication. Be more flexible in allowing people to take their methadone with them. And there was a lot of resistance to that because these systems are like just used to the models that they have. And so kind of understanding how these changes happen with organizations that are sort of like somewhat under-resourced is an interesting set of questions that we have as part of this work. So we have a mixed methods approach where we're using administrative data, which is, to underscore the point Steve just made, is like bringing together the Medicaid data. The Medicaid data tells us about the services that were delivered by the treatment providers. So we get at sort of, the billing for, individual and group counseling services, but it also we're able to identify how many of those were telehealth as opposed to sort of in-person visits. Things like toxicology we're able to observe in the Medicaid data. And so with that, and sort of like, and also even sort of like, peer counseling, because the state funds or reimburses peer counseling. So the data tells us what the client data system tells us the qualities of the individual, race, ethnicity, whether they have criminal justice mandates, or some of the examples of the kind of data we get from that. And we're able to explore variation across the system and take into account how much of that is driven by those individual characteristics of the patients to adjust for that. Then we look at sort of like who are the high performers and low performers when it comes to sort of adoption of these services and retaining clients and treatment to follow up with interviews. This is just a quick flyby on some of the things that the data are telling us. This is, again, sort of the year after the first year of COVID, looking at sort of who was benefiting from telehealth, and on the left side, and then on the right side, who is benefiting from getting take-home medication. On the left-hand side with telehealth, what we're looking at is volume of telehealth and who was getting more and who was getting less in relative terms. And this is all adjusted for other personal sociodemographic characteristics. And what we see that, females are getting more telehealth visits than males. That's the comparator. And then in comparison to sort of white individuals, individuals from communities of color we're getting less volume of telehealth visits than others. So really sort of, speaks to sort of this disparities concern that, the state has, as well as we do, as, by and that we want to address in our future work. Similarly, on the right-hand side, what we're looking at is sort of at the organizational level. So the data we had on take-home medication for this analysis was at the organizational level, what proportion of their clients were getting, different levels of take-homes. And what you'll see is we broke it down, the data into were they getting 1 week's worth of take-home medication, 2 weeks worth, or, sort of like, having to come in twice a month. And then, whether they got a full month's worth of take-home medication. The comparator here is not getting, having to come in frequently during the week to get their medication. And so what
That's
you
actually sort of making how should I put it? It is sort of making a scientific advantage out of a limitation, because in essence you're creating an instrumental variable.
Yes. Yeah. So in here, what you see on the left-hand side is the proportion of people within that organization that are of this characteristic. So the proportion of individuals within that are getting treatment in that program that are female. And so the way to interpret the right likelihood is per percentage point increase in the number of females, that's the increased likelihood that they're going to get take-home medication. And so just to get to the bottom line here, women are getting more take-home medication, or women in organizations in which there's more women are getting more take-home medication, proportionally more women. Organizations where there's proportionally more people of color are getting less take-home medication. I'm going to plot.
That refers to that client base, right?
So yes, a
Organizations
proportion.
with more women.
Clients, that's right. Yes.
And you're controlling for geography.
So in this model, we have controls for geography, yes.
Because, that's kind of an interesting thing, because one thinks, in the New Jersey context, for example, one thinks about methadone clinics that are like in the southern part of the state, more likely to be serving the white population, as having been more resistant to the COVID changes and more resistant to moving to take homes. Whereas the inner city ones were more responsive. And in New York, of course, you've got a whole larger scale of geography in different regions.
Yeah, I think that's an important, with these state level studies, like you're saying, states have a big variation in geographical characteristics, and that's a feature to exploit in these kinds of studies. Yeah. I'm gonna, because of the limitations of time, I'm really gonna summarize this very quickly. This is some results of going to talk to, actually having qualitative interviews with 3 different levels of staff within the clinics that were high performing versus low performing, with sort of, these changes in service delivery. We were talking about sort of program directors within these clinics, sometimes medical directors, and then sort of supervisors and sort of line staff. And, these are some broad themes, but broadly speaking, you see within the system, there's this ongoing transition that's happening just as we speak, with sort of the traditional model that's steeped in the disease model of addictions, that has a real focus on abstinence as the goal of treatment, and sort of this emerging model, and this emerging model that's being pushed by the state that's much more person-centered, that makes the treatment engagement more of a collaboration between provider and patient in defining goals and the manner in which treatment is provided. And this tension is sort of emerging in all of this. And the public health emergency put this on overdrive, just because sort of some of the things providing counseling at a distance without having the person in front of you, sometimes doing it on the phone where you can't observe them, not being able to provide do toxicology, being forced to provide take-home medication is something that sort of is contrary to some of the traditional notions of treatment. And the workforce within these clinics is really struggling with it, but also the clinic culture is under duress. And how they kind of make this transition is something that we're sort of exploring and trying to see, sort of what are the factors that are associated with sort of this transition that moves in a more sort of, I'll use the word progressive approach to treatment.
Did the financial implications
for the TPs come up in these interviews?
So, in our separate study on with the methadone grant, we've kind of explored how financing sort of has an impact. It's a part of the story, but what is remarkable to me is that the clinical team and the team that's doing revenue are really not talking to each other that much. So the clinicians who are making the decisions are really not sort of like being case conferencing with the folks that are sort of like doing billing. So it's not as direct a connection as one would expect. The other thing I'll note is that New York sort of like adopted, Medicare came out and started paying for methadone in 2020, in January 2020, and had built in a bundled rate. And New York adopted that for Medicaid, trying to sort of buttress against sort of like, the revenue shortfall that might come from doing, weekly dosing or biweekly
That's
dosing.
really important, and it's something that might impact vary by states. If you listen to what Mark Perino says, who's the director of the sort of National Association of the OTPs, you hear primarily a traditional clinical point of view. These individuals can't be trusted. They have to be, they have to be supervised very closely, or it won't work. And you can't be trusted with the take homes, but behind it, for many of the facilities, is a financial motivation, especially with the profit facilities. But this very likely will vary as to what, of course, states that have some of the financing.
And
So
yet,
it should be neutral to a facility, whether you get take homes or not.
And what's important here is that there's state variation in sort of the regulatory environment, and I think some of those things really are driven more aggressively in other Western states where, like, it's a lighter regulatory hold.
Exactly.
Yeah. I'm going to go a little bit over, but I just want to sort of like highlight. We have a study that's about to wrap up where we're trying to coach clinics on quality improvement. This is driven by some of those policy shifts that were happening within Medicaid on value-based purchasing, and conversations we were having with stakeholders, and how well prepared were clinics to sort of make this shift. And the general answer is not very well prepared. So you need a different level of, you need MBAs to like really understand these things. And a lot of these clinics have people who grew up wanting to give treatment to people, not necessarily understand sort of all the issues that are involved. So we created this study, it's a step wedge design, where we sort of like we're working with 28 different clinics, using a facilitation model, which is inspired by implementation science, to sort of like really help these organizations sort of think about quality measures and then do sort of change management practices. And we're going to track the outcomes through the administrative data, to be able to sort of like, see sort of for these programs, we can track them across time without having to invest in the full sort of like, data capture that you might have in other kinds of studies. The other benefit of this is that we can, for clinics that are not participating in the program, we can still see their data, so we can better control for secular trends that are happening across the system, across the life of the step wedge trial. So this data was presented at the Addictions Health Service Research in February by, this speaks to sort of like our partnership. The person presenting this was from Oasis. So I'm going to, represent those slides. And so the focus here, this is a simple pre-post kind of analysis. So this is not the full multivariable mixed methods adjusted, analysis of the final outcomes that will come out, later this year. And so what we're looking is pre-post on use of medications for opioid use disorder, pharmacotherapy for opioid use disorder, whether or not patients are getting it. We're also looking here at whether they're retained on pharmacotherapy for 6 months or more. And we're also looking at sort of like, do they stay engaged with the treatment system for at least 6 months? On all these measures, the current system fails miserably, broadly speaking, across the country. And so just to highlight, this is a facilitation model. We got the award. It was one of these R61, R33 multi-phase projects where you have a phase to do intervention development. And then if you prove to NIDA that you kind of hit your milestones, then you get approved for the second phase. So within the year, we hit our milestones and we got approved for the second phase. First year development, pre-COVID. Second phase, when we were going out into the field, COVID hits. And so we had to pivot, just like everybody else, and sort of like, kind of adapt the model to be provided through telehealth, which in the end sort of like, kind of like makes it much more scalable. So this is a facilitation model, coaches working with each one of the clinics with the change teams that were formed at each clinic. One of the important things that we heard in the stakeholder meetings is the import that include managed care companies, that included providers, included patients. And these quality measures, one of the things that's often missing is the patient voice. So, we were driven to sort of create a measure that could be used. We asked the providers and the managed care companies, what would that measure look like? And they said it had to be simple, it had to be easy to incorporate into clinical care, it had to be clinically meaningful, and it had to work with varying ranges of educational attainment of the patients. So, and is there a model for that? We asked the stakeholders in the room, and they said the PHQ-9 was something that the PHQ-9 is a measure for depression that's often used with quality improvement within the depression field. So we created an eight item sort of questionnaire that kind of fits all those. To ease administration, we devised sort of an electronic portal to sort of like be able to capture the data directly from the patients. And there were lots of lessons learned and what happened during the trial with this that I can talk to a little bit. But just to sort of get to some of the results quickly, the pre and post period, the demographics are relatively consistent within these clinics. They're sort of like average age of 40, primarily male, sort of a large proportion of communities of color that sort of like are indicative or reflective of what the treatment system in New York looks like. And again, this is pre-post unadjusted, but sort of like we are seeing increases in use of medication, pharmacotherapy for opioid use disorder. We're seeing increases in retention on pharmacotherapy, and we're seeing very large increases in retention in treatment within these clinics. So promising, the
retention improvements as a result of coaching.
So like this real kind of coming in and focusing on, and it's hard to know, we'll have to do the full analysis, but sort of real focus on quality improvement within the program, driven by measures. There's a big part of what we bring, which is like training on medications, which they found very valuable, the line staff, as well as this the TPA-8, which is that patient measure, which gets them focused on sort of querying the patients on their status and incorporating that into the counseling. So we don't know how to disaggregate that. And again, this is preliminary. It might disappear when we do the full analysis. I want to just sort of like highlight that this has led to a quality measurement and management research center that we're coming online. We're doing this in partnership with Oasis. Shinazo, the commissioner, has said that she wants a data-driven system. She wants to invest in sort of improving the data capture within New York. So we're working together, providing our expertise, but also their expertise and sort of like about the clinical system and, what is feasible within the data capture system to develop measurement system. There's 3 projects. One of them is focused on measurement development and for this specific system. One of them is to improve the client questionnaire that we are developing with them. That we developed in the prior trial, taking some of the lessons learned to sort of improve it. And then finally, sort of like, testing out, are we really moving the needle on quality of care outcomes for folks? This is just to say that they're interrelated. This can't happen without the help of people. Some very important people at the state, but also, partners at the University of Connecticut, Cornell, and, and I already mentioned Tom Diano. And this is not everybody on the team, but sort of without them, you can't stand this up. Thank you. I went over. There were some questions along the way, so I hope it was engaging. But we have a little bit of time.
Very interesting overview. You, never the slides mentioned organizational factors.
Yes.
Out of your business degree, and I know people at the Wagner School too.
Yeah.
That are facilitators of presumably higher quality care. Can you talk just a little bit about what organizational factors you zeroed in on?
Yes, yeah, thank you for the question. So, with the help of Tom Diano, right now we're sort of using something called institutional theory to sort of really understand sort of the culture of these organizations and thinking of them as organizations as social entities. So, the businessman comes in and he breaks it down into the finance group, the marketing folks, the, through, the core leadership at the top and, the salespeople. But this is more thinking about sort of like, how an organization, formulates its beliefs about sort of what is true about the world and how those beliefs feed into values about sort of what should be done. And then sort of how those get built into beliefs. And for us, it's useful in understanding sort of this transitions that we're seeing right now. So a lot of the organizations that are out there that are providing care based on the traditional models, they think they're doing good because that's based on their belief systems. And right now, sort of like our challenge is to understand what those beliefs are, how those like inform their norms, but like how to sort of like, get to a point where we can inform on sort of like how can we make changes to culture, which are resistant to change. So, but and that's the stuff where like Tom is really sort of like is very helpful in us thinking through.
So they sort of measure, I understand the cultural focus, to measure it. You've got various instruments to try and.
We haven't gotten to the part to specifically measuring it, so like, but it is informing things like, for example, with the we are developing for the methadone study where we're trying to move the needle on how flexible they are in offering methadone, looking at sort of like things that Steve was alluding to, which is sort of like, their ability to trust patients, their sort of like sense of sort of, the relative risk, how much they weigh the clinical benefit of take-home medications. So those are the kinds of things that we're sort of starting to build. Yeah.
Jennifer, did you want to have or Ethan? Jennifer and Ethan are two people who are maybe particularly interested in sort of the implementation process of the step wedge.
Mm-hmm.
So maybe you have some questions in that area.
Many. So working with Ethan, really at a beginning stage of learning how to design step wedge trial and similar study designs, moving away, a little bit from more of the observational research that I'm used to doing.
Yes.
And part of that is to actually look within the RWJ health system, the emergency departments have been implementing quality metrics around initiating buprenorphine among naloxone reverse patients. And so we're actually working on developing a pilot study, working with the health system, looking specifically at this point at a CME provider education program that they're about to roll out. So that's sort of the high level. And then, I would have any number of questions about maybe pitfalls or, ways of sort of designing that to be successful, and any advice you have for new.
Sure.
Brand new to that.
My first piece of advice is find a good statistician. And so we got Chuck Cleland at NYU to sort of help us with that. One of the things that we found both in review, but also sort of later on when we were kind of talking with sort of like, people that were within the same network of programs that were funded under the same mechanism, is there's a real worry right now of secular events not being adequately controlled for in these step wedge designs. We don't have a great answer for that, but this idea of sort of like finding other systems that where you have the data for them to sort of, kind of like track them separately, almost as a new condition, is sort of like, part of the way that we're thinking about sort of like adjusting for or taking that into account.
So in these studies, this is something that always seems to come up. The clinics were randomized as to what condition they were going to be in.
So we only have one condition in each one of these trials, and so they're just randomized for order of participation.
Right, randomized for.
Yep.
Right. Did you have any logistical challenges or acceptability challenges in clinics agreeing to be randomized?
So the first part, with these clinics, they're all overwhelmed, COVID and workforce issues. So everybody's saying that they're overstrained.
Right.
So we're falling over backwards to be accommodating. And we know the guy going in, the first thing we say is, we know you're busy, but we're gonna work with you. We're gonna make this sort of like adapt this to you. Many clinics, in both trials, we've had times when the clinic said, right now is a bad time, maybe in the future.
Right.
And we said, okay, we'll put you in the randomization. When the time comes, we'll talk to you again.
Right.
And so far, we've been fortunate that when we came back to the clinics, they still had hesitations, but at that point, we could talk them into sort of participating. But that's always a worry that the later cohorts are gonna sort of drop out because the circumstances on the ground have changed. Yeah.
And then the converse problem that you were alluding to is with secular trend or
Yep.
another version of the same thing.
Yes.
Do the clinics that didn't get randomized end up making similar changes? Didn't get randomized to the intervention, end up making similar changes.
Yeah, we've had, and I'll tell you so we have a stepwise design for the methadone grant.
Right.
And so we're working them sort of, in cohorts. And the worry for me in the beginning and for, people that are asking me about it is like, as the new SAMHSA guidelines come on board and the regulations are actually baked in, which just happened, like, are we just going to see system change across the board? In that, particularly because that is sort of, voices is still kind of like voicing the, you should be more flexible. They're really kind of like saying the whole, that to the whole system. Would we see change? So far, we've seen the opposite, where people are reverting back to former practices. So that hasn't materialized, but it is always a concern.
Just follow up. So what about using claims to be looking at, are you randomizing the entire system? Or do you have programs that are not actually at all part of that you could use as like control to try to get at that secular?
That's exactly what we hope to do, which is to say, we're going to look at the other non-participating clinics to sort of be sort of like another adjustment control, like you say.
Not just using the clinic
Yes.
itself, free period as its own control,
Yes.
but having non-intervention.
But does your qualitative research support that the randomized intervention, the coaching, I guess it's kind of coaching, is sort of the what's the word? The determinative factor in practice change versus the many other things that are going on at the same time that are driving practice change, of course.
The first study that we have with the stepwise design is the quality improvement coaching thing. And that's the data that I have right now, which says something's happening. It's looking promising.
Right.
We'll see when we kind of do the full study, whether it's really the intervention or, just everybody changed at the same time. It's hard to believe that they're, I mean, things look good for now. Yeah. Ethan, you've been trying to dive in, yeah.
To get like deeper into the weeds, and then I guess Steve will give everyone lunch.
Yes.
After I more people, but I guess I'm curious, like how many steps, the duration of the steps, and how many clinics are going in each step.
Yes. So for the previous quality improvement grant, we had there was 28 clinics that were randomized. I think, and there was roughly 4 to 5 clinics participating in each step, and we had 2 facilitators. So, it was actually 5 in each step until, the latter ones. And it was generally like 2 to 3 that we were trying to bounce it up for each facilitator. For that project, it was the participation was for a year long, but it was in 2 phases. The first phase was intensive, where they were meeting with them sort of like, bi-weekly over the first 6 months period. And then there was what I euphemistically called call a friend period, where like, they could, reach out. What we did find with that project, and it's the same thing's playing out with the methadone project too, is we never get started right when we say that we're going to get started. Because like scheduling is just a nightmare. So things always get delayed. So the first 6 month always, period always bleeds into that 6 month call a friend period. So with the methadone, it's 27 clinics that we finally kind of like, got. We originally want 36. We could only wrestle in 27. I think that's roughly 4 per cohort. They're only 6 months long. I think that's 5. It might be 6. I can't remember off the top of my head, but cohorts, and it is rapid fire. So like, we're there again, we're kind of having difficulty getting them started on time. So like there's a little bit of bleed into the next cohort, but there's less of one thing that we learned along the way with these clinics is for the first one, we were very prescriptive on like, what they should be doing by week. And that became, almost untenable after a while. And we're getting a lot of resistance from the methadone clinics. They were saying they're too busy, and also they really, are skeptical that we know any better than they about treatment, methadone treatment. So we're taking more of a motivational interviewing, kind of informed, kind of like perspective with them, where we're kind of like, bringing them information, but using more of a dialogue, and we're trying to coach our coaches on that. So there it's much more flexible. We're hoping to sort of, not be so caught up in sort of like, the strictures of having a very sort of structured intervention. Does that answer your question, Ethan?
Yeah, no, I mean, at the end of the day, like the step wedge is a more pragmatic design.
Yes.
But.
Has its
doesn't that what
complications.
you're saying in grant? Like,
Yes.
there's sludge and friction, like in every
Yes.
step of the way. So I'm just curious in the real world how people adapt. And also, I think you're smart for realizing at the end of the day, this has to be like the intervention has to be
Yes.
pragmatic, because no one's going to jam like a standard protocol into a place that doesn't want it.
And
Even if you could
yeah.
like paralyze people
Yes.
for 6 months and do directly observed intervention therapy.
Yeah.
That's just not replicable at all. And at the end of the day, you just need to work with people. Like, it's going to mess up a little bit of knowing like who got what drug and at what dose.
Yes.
But that's the way I think we have to.
It's
you've been doing this for 15, 20 years.
Yeah.
If you don't work with them, like the opposite is working against them. That's not really a recipe for like engagement.
Yes, it's noisier, but it's sort of like it's the there's a pragmatism that has to come into this. Yeah.
That's why I thought the reimbursement piece was so important, because who was it that said that it's extremely hard to get a person to change their mind on something that will affect their pocketbook if they change their mind in that way? Yeah. Okay, other questions. Jose, did you have any questions about sort of the and Jose, you might want to say a word about the IPHD and these structural efforts to create a platform for integrating the state data service.
Agree. Sorry to interrupt. We have time together in this room still till 2, but we have lunch outside to grab, so maybe we can do food for those on Zoom. We'll wrap up with that and grab some food and come back.
Yeah.
For that discussion, if that's okay. I just want to make sure.
Perfect.
Time to eat what we have. But thank you again, Dr. Nevers, and for those joining.
Perfect.
Thank you. Thank you.